Welcome everyone to tonight's webinar. I'm just going to give everyone a chance to join, but thank you so much for joining us this evening. Welcome to everyone who's joining at the moment. You're just giving it just a minute just to make sure everyone joins and yeah. Okay, I think the number has stopped going up, so I'm sure there are a few late stragglers, but that's fine. I'll just kick it off and just introduce myself. So my name's Aoife Bradson, and I'm the head of marketing comms for Sims IVF. Just a little bit about Sims. So we are one of the largest providers of fertility treatment in Ireland. So we have 6 locations throughout Ireland. So we have 3 main clinics. So we have one clinic in Clonskea in South Dublin, we've one clinic in North Dublin and Swords, and we've a clinic down in Cork. And then we also have satellite clinics, which actually provide kind of bloods and scans throughout your cycle, so you don't have to keep traveling to the main clinics for every procedure. So we have them in Carlow, Dundalk and Limerick. And we're also part of Virtus Health, which is a kind of a global provider of fertility treatment. So they have clinics all across the world, Australia, Singapore, Denmark, UK. So we have a great kind of network of support there. Just a little bit about tonight. So as a thank you for joining us tonight, we will be offering anyone a half price consult. So I'll send you on the details in an email. And tomorrow or over the weekend, if you want to avail of that, usually it's €180, but it's down to €90. So we're joined tonight by Dr. Alex Aldape, who is our medical director, and he is based mainly in our Clonskea clinic. And he's going to just talk about everything IVF and kind of testing and treatment related. If you have any questions at all, just pop them into the Q&A box below, and we will answer them at the end of the presentation. So yeah, just pop any queries in there. Anything I can answer, I will. But otherwise, we'll leave it up to Alex at the end. So I'll hand it over to you, Dr. Alex.
Thank you, Aoife. Thank you so much for the kind introduction. So so my name is Alejandro Aldape, but yeah, here I'm better known as Dr. Alex, as Aoife just mentioned before. So for today, what we're going to do, we're going to talk pretty much about fertility, okay? So including treatments, investigations, and what will be the journey for patients that they deciding to go with us for their treatment. So just let me share here the screen. I'm just checking again that you can see those slides there. Are we okay with the slides?
Yeah, all good.
Okay, fantastic. So then here we go then. So the first thing that I want to cover today, well, what we have for this session is, of course, this element. So we are going to talk about the journey, the general journey and the experience for all of our patients when they're coming to our clinic, to one of our locations for doing treatment. We are also going to talk about what will be the most common causes of infertility. We're going to talk about as well the treatments, and then also we're going to talk about the investigation. So it's going to be probably like 45 minutes, 1 hour of our time, but I hope that you find this interesting. And please, of course, if there's something that I'm not covered today, or you have any questions, please just drop those questions in the Q&A, and I'm happy to answer those at the end. So generally speaking, the overview for the patient will be, or for the couple, it will be as follows. So essentially, what happens normally at the beginning is that the patients or the couple, they go directly to our website. Sometimes they are referred by the GP, and they fill a new patient form. Once we are getting that new patient form, our admin staff is going to facilitate and accommodate an initial consultation with one of our doctors. And of course, during that initial consultations, what we will do, we're going to get the medical background. So that's the first step. So essentially, we need to get the medical history. have a better understanding if there's anything in the background that can potentially affect fertility, of course. After getting that initial that medical history, what we normally do is, if possible, we get to a diagnostic to tell you exactly what is the reason why infertility is happening. And of course, sometimes with the initial consultation, we can have an idea about what's going on, but not necessarily the final diagnostic. And that is the reason why we will request for some investigations on both sides, female, male partners, and essentially it is several investigations that we follow doctors and algorithm, trying to find out what is the main reason or the main cause for not getting there, for not achieving pregnancy. Then after this, what happens is that we send a request to nursing team, an order, and then the nursing team is going to come back to you, to patients, and they're going to schedule all the investigations that we have proposed during the initial consultation. And of course, this could be blood tests, this could be scans, this could be, for instance, semen assessment, for instance, DNA fragmentation. And once we have all together, we normally we have in a return consultation. And in that return consultation, we are finalizing the diagnostic, and of course, we are preparing the treatment plan for you. So once the treatment plan is in place, so essentially what happens afterwards is that there's follow-up by nursing team. And of course, once we know exactly what treatment is and when you're going to start, you're going to get all the instructions. It's very important to highlight here that that we do have an application that the name is SALB, SALBE, or SALBE. That's an application, that's an app that you can have on your phone. And with that one, you receive pretty much all the information regarding your treatment plan. Very, I mean, black and white, very easy to read and follow regarding all the steps of your treatment. At the same time, you can have direct communication to us with that application. So, and all the feedback that we are receiving from our patients, it's very positive regarding, of course, communication, regarding, of course, how easy it is to interact with us and how quick we can come back to you if there is any kind of questions or any problems that are arising during the treatment. And then, of course, once we are doing the treatment at the end, we normally, for all of our patients, regardless of the outcome, we come back to them to see, yeah, to get feedback, to see how was the experience. And of course, if there's any other kind of follow-up that we need to do. But these are the 6 steps, that is the whole journey. It depends, of course, on many factors. It depends, of course, of the treatment that the patient or couple they are going to do. It also depends on, well, availability of the clinic, which, by the way, at the moment, we do not have waiting lists. So pretty much it's pretty straightforward. So what I'm trying to say here is that from filling the form, number 1 up to number 6, it could be as close as quick as 6 or 8 weeks potentially, if we are following this step by step, and if we are doing this very organized and very fluent. So yeah, so that's pretty much the journey in general. Okay, so infertility, probably many of you are aware about this definition and what infertility is, but essentially for couples that they've been trying for a baby for at least 1 year and not been able to get pregnant, so that particular couple will be labeled with the diagnostic of infertility. It is also true that sometimes we doctors, we do not advise necessarily to wait the full year for kind of requesting or looking for help. And essentially, because as you know, probably, and as we know, so age does matter. So age is a very important factor when it comes to getting pregnant and infertility. And for that reason, now 2023, what we advise will be when couples, when they are trying for a baby, particularly when both partners, they are above 35 years old, we definitely strongly advise that, okay, start trying for a baby, of course. And if after 5-6 months you're seeing that you are not getting there, not to wait the full year, but request an initial consultation with us. Sometimes could be something as simple as not having the ovulation, so we give you some kind of medication to produce the ovulation and that's it. But sometimes could be something different in the background. So for that reason, it will never harm to have an initial consultation with one of our doctors. And again, particularly if it's more than 1 year, or if you are both above 35 years old and it's more than 6 months, the recommendation will be the same to asking for requesting the initial consultation. So it's very prevalent, it's very common. Infertility is 1 in 5 couples, and which is as you can see, is very prevalent. The other thing that we need to highlight here is that infertility could be, I mean, there's classifications of this. We can say primary infertility when we are talking about a couple that never ever been pregnant and never even having an ongoing pregnancy. Or we can talk about secondary infertility when we are talking about couples that they do have a child or they do have children, but they are struggling to get pregnant again. Infertility and subfertility, well, this is a little bit arbitrary, but essentially what means is that sometimes we do have a very clear reason why a couple cannot get pregnant. For instance, if we are doing a semen assessment and we are identifying that there's no sperm there, that definitely it will be infertility. But sometimes we can see that there's some sperm, some million of sperm, but a little bit below the standards that we're going to discuss today. And that potentially, not necessarily it is infertility, but will be classified more as subfertility, meaning that the chances of conceiving naturally definitely are going to be reduced. And yes, sometimes we are not saying about infertility, but it's just single women looking for pregnancy. So that will be just reproductive choice. And of course, single patients, single ladies will not be classified as infertile. Yeah, going back to the age, yeah, age does matter. And it's very interesting because a few years ago, not so far away, you see, like 10 years probably, yeah, we've been kind of more focused on women's side. Like, of course, we know that age does matter for women, but we were pretty much kind of not taking too much into consideration male age. And now we know that that was completely wrong. So essentially, both male and female, we are losing our ability of reproduction with time, and that's for everybody. Okay, here in this chart, as you can see, if we consider as ideal age for getting pregnant 20 to 25, you will see there that, well, if the fertility we can consider this at 100%, it's very interesting to see how at 35 years old it is just half of that, and how at 40 it is just 25 of the total fertility or the total capacity for a woman. In men, it's slightly different, but still age does matter. So essentially, men we lose 50% of our capacity when it comes to fertility around 35 years old. Okay, but then the difference is that we still can continue being producing good sperm quality, or a sperm that will be considered good for reproduction up to around 50, 55 years old. And then at that point also decline. So essentially what I'm trying to say here is that, yeah, so for both age does matter, but particularly for women, it is more relevant trying to conceive before 40. For men as well, but what we know is that it could be a little bit more prolonged in terms of age, and we would recommend to kind of doing all the reproduction before 50. Sometimes could be up to 55, but of course, then the probability start to decrease very, very quickly. Please note that here we are not considering about intercourse or sex. We are just talking about fertility. Okay, when it comes to causes of infertility, what we doctors do, we normally follow an algorithm. So what we want to check, of course, is on the female side, we want to check eggs, we want to check ovaries, we want to check the uterus, all these parts checked. And then on male side, what we want to check, of course, it is the sperm. Okay, we check some parameters there. And if we are not finding the reason there, also we need to check the housing as well. So meaning, of course, the uterus, fallopian tubes, and the cavity, of course, of the womb. Okay, that's pretty much the algorithm that we follow. This does not mean that these are the only 3 elements that are involved for reproduction, but the reason why we keep it simple and we talk about these 3 is because, in fairness, and to be honest, 80–85% of the times we are finding the reason in one of these 3, okay? Yeah, so for instance, when it comes to egg, what we want to check, it is quality and supply. Quality, it will be more given by age, okay? And supply, where we do an investigation that we are going to talk in a few minutes, but the name is AMH for checking, of course, the anti-mullerian hormone. The sperm, it's simpler compared to checking the supply and quality. With the sperm, what we normally do is, of course, asking men to produce a sperm sample so we can check, of course, several parameters, and we can come back to tell you what's going on. And about the housing, we, of course, can do scans and transvaginal scan. We can do other investigations like SIS, and we're going to cover those as well. But mainly, the most common reasons, and the most common reason here in Ireland of infertility would be low ovarian reserve, meaning low supply of eggs. Yeah, so the infertility causes also can be 30% male factor, 30% female factor, something in between 10 to 20%, something that we call combined factor or mixed factor, meaning that potentially it could be a mix of low ovarian reserve, but at the same time, low sperm concentration, for instance, or low motility. And then we have 20–25% max of something that is called unexplained infertility, meaning that we have covered pretty much all the investigations that we can do, and we still do not have the full diagnostic, and we don't have the reason. We cannot tell you the reason why. Particularly the couple is not getting, why you are not getting pregnant. Okay, so but most of the times we are able to identify at least one cause. Okay, so then covering a little bit about the investigations. Well, as I was telling you before, we normally separate this female and male investigations. Okay, so if we go back to the algorithm that we normally follow, that I was explaining you, eggs, the sperm, and cavity or housing. So we normally start, for instance, with male, and the reason is because, of course, getting a sperm sample, well, it is not painful most of the times. And of course, we can get a very good assessment regarding what's going on with the sperm. So in the semen analysis, that will be the first, the initial investigation is not the only one, but the semen assessment is very good because with this one, we can get volume, sperm concentration, motility, morphology. Those are the parameters that we always want to check. Just to give you an idea, volume will be the amount of the ejaculation. So according to WHO, 2010, so this should be at least 1.5 mLs, 1.5 milliliters. So then we have the number, and that's the most important parameter when it comes to fertility and when it comes to the semen assessment. How many million per each milliliter of sperm? So, and that is measured normally in million. Okay, so what we would like to see is that ideally should be above 20, but it will be still considered normal, about 15 million per each milliliter. So then we have the motility, meaning the movement of the sperm. So the movement of the sperm should be, as you can see there on the screen, at least, I mean, ideally about 50%, but still the cutoff point will be good at 32%. And then last but not least, the morphology. So the morphology will be the shape of the sperm, meaning that, of course, there are some sperms that they have 2 tails, for instance, or 2 heads, or short tail or long head. And the morphology is also important. And this one should be at least 4%. And if we go with the parameters that we are using with the macular camera, it will be at least 35%, as you can see there on the screen. This is the initial assessment, but it's not the only assessment that we can provide for men. For instance, when we are seeing that the sperm concentration is low, under 5 million, sometimes we need to supplement this initial assessment with something else. Like, for instance, sometimes will be fish test for checking the genetic of the sperm. Sometimes could be the DNA fragmentation. As you probably know, DNA fragmentation could be related to fertilization failure, could be related to miscarriages as well. And as well, we sometimes we check hormones because doctors sometimes we are very focused on women, but also on male side we need to check hormones like FSH, TSH, LH, testosterone, all this. So it is important to have this assessment because the more information we can get on both partners, the better the diagnostic is going to be, and therefore the better the treatment is going to be, and therefore the prognosis. So it is important to get this assessment. Sometimes it's very straightforward. Sometimes with the medical history and the initial assessment with the semen analysis, we are in a very good position to tell you what's going on. But sometimes it's not as straightforward as we are just saying here, particularly for patients that they have tried already IVF cycle, more investigations normally will be recommended. On female side, well, we were saying about the AMH, getting some blood tests. For instance, in SIMS, there's one investigation that we do that the name is female fertility profile. So it's a very comprehensive test that we're doing with blood, so we can check from vitamin D, which is very important for egg quality, for instance, and the development of the embryo, up to checking TSH, the thyroid gland, checking the full blood count. It's a panel that we will recommend, and in that panel it is of course included the AMH, which is probably one of the most important parameters to knowing about the supply of the eggs. Yeah, there is another anatomical testing I was just mentioning before about the ultrasound, for instance. The ultrasound, most of the times we prefer to perform that one transvaginally. And the reason is because, of course, when we are using a probe that we can situate transvaginally, that we can put it transvaginally, so we are closer. We're very close to the anatomy, to female anatomy. We're very close to the womb. We are very close to the uterus. We are very close to the ovaries. So the images and the assessment that we can do, it will be always better compared to an abdominal scan, for instance. There is other investigations. Sometimes we are sure that there's no problems with the womb, that there is no fibroids, that there is no polyps, that there is no cysts. But you see, with the conventional ultrasound, we doctors, we cannot check and assess the fallopian tubes. So in order to do this, most of the times what we will recommend, it is something that is called SIS. And the SIS, it is an investigation for checking the fallopian tubes, where essentially what we do, we place the speculum like a pap smear, we clean the cervix, we pass a catheter inside into the womb, and we are filling up the womb with water. I'm going to explain you that in the next slide or two. Okay, so then blood test, as I was just telling you, it's a very comprehensive, the female fertility profile. We're checking testosterone, rubella, full blood count, prolactin, TSH, because, sorry, all these could be related to a certain degree with infertility. Sometimes not necessarily infertility as such, but potentially miscarriages or biochemical pregnancies. Just to give you an idea, the thyroid gland, when we are checking the TSH, is very important, because when this one, it is above 4.2, well, the probability of having a biochemical pregnancy or a miscarriage is going to be increased. So that is the reason why it's important to check this. Prolactin, because patients that they are not having regular menstrual cycles, sometimes the reason is having a high prolactin, so that's very easily fixed with a tablet, for instance. But it's just for you to give you an idea why it's important to get the full profile of the female fertility profile. Yeah, I was talking previously about the AMH. AMH stands for anti-Mullerian hormone. This investigation, as I was telling you as well before, is pretty much one of the most, is if not the most important, is one of the most important investigations. And the reason is because it's very accurate for telling us what's going on with the ovarian reserve. Ovarian reserve, and that's a concept that I want to explain a little bit more about, because for male and for female, it is completely different. Okay, so for male, we are producing sperm every day, and the sperm from one cell to become a mature sperm takes 72 to 90 days. Okay, so it could be up to 3 months. Whereas female, the difference is that you're born with a specific number of eggs. No doctor, not myself, not other doctors, we won't be in a good position to tell you exactly what is your number. Like, for instance, 8,403 eggs is not the way the AMH works, okay? but definitely is going to tell you where you are, okay, when it comes to the supply, when it comes to the reserve. So you're born with a specific number. That number was calculated in around 2 or 3 million of eggs. But the thing is, like when women start with the menstrual period, around 13, 10, 13, 14 years old, that number drops to 500,000 eggs. And then every month, female, you're going to spend anything in between 500 to 1,000 of eggs per month. Okay. I know that when I'm saying this to my patients, many times I'm getting back, Alex, but that's not true because I read that every time we are ovulating only one egg. And that's totally right. Most of the times when women, when they're having regular menstrual cycles, they are going to ovulate one egg. But the thing is, like, there is another 400 or another 500 that they are pushing the one to be released, to be ovulated. And those ones that are pushing the one, they are gone for good. So essentially, you are not going to get them back. So that is the reason why, in long story short, you are ovulating one, but you are spending 400, 500, okay? And the problem is that we cannot calculate that very accurate because that is given by genetic. Okay, so the best way of tracking about fertility, or the best way of knowing how your fertility is going to be, is tracking back your family. Okay, so knowing about your mother, your aunt, how was fertility for them, when when did they have the menopause? All these kind of questions are important for you to know. Going back to the AMH, so essentially what we have now, 2023, you can see there a chart that is just here if you follow the arrow of my mouse. So essentially we have done the same investigation, the AMH to hundreds of thousands of women across all the world, and we have plotted them out in that chart. So then you have like the levels there. So on the y axis, you're going to see the level, and then on the x-axis will be age. So for instance, if somebody's 30 years old and the AMH is 20, that will be fantastic. That will be a very good result. Okay, please note that I'm saying 20, it is a fantastic result, and I'm not saying 40 or 50. Okay, so the reason is because having really high AMH, although it is not in the Rotterdam criteria for doing the diagnosis of PCOS, polycystic ovaries. So yeah, essentially high AMH could be related to polycystic ovarian syndrome. So that's here, PCOS. And of course, very low AMH will be, well, low ovarian reserve. So for that reason, what we would like to see, just to give you an idea, is that all of our patients, they are in this kind of yellowish or orange-ish kind of frame here, range here, okay? So 30 will be around like 20, 35 around 15, just to give you a rough idea. Yeah, so the ovarian reserve, as I was just mentioned before, could be normal, could be very high, and sometimes not necessarily to be related to polycystic ovaries, or could be very low, and that's something that we doctors call as diminished ovarian reserve. This is important to know because based on this, what we normally do, of course, is a full assessment of the couple or a full assessment of the patient. Based on this ovarian reserve, we can tailor the treatments as well. And we're going to discuss that in a minute. The SIS that I was mentioning previously, the saline infusion sonography, yeah, it takes like 10 or 15 minutes, no more than that. And essentially, it's about doing an internal scan, on that internal scan to take some photographs of the womb, to take some photographs of the ovaries as well. And then we pass a catheter inside into the womb, into the cavity of the uterus, and we are filling up the womb with water. Okay, so what you're seeing here, again, if you follow the arrow of my mouse, this will be the cavity after instilling, after passing the water inside into the womb. And this is completely normal, by the way. So this is the image that we would like to see, that everything is smooth, that there's no polyps, that there is no fibroids, because polyps and fibroids, they can be a cause of infertility. When the fibers are inside into the cavity of the womb, and when the polyps are big meaning more than 2 centimeters. And then here we have the fallopian tube. So essentially, once we finish with the assessment of the cavity, then we're using a foam contrast for checking the fallopian tubes, because of course, if we want to, for instance, if we want to offer And insemination it will be very important to know that the fallopian tubes are open. Otherwise the probability of getting pregnant with an insemination will be close to zero. But what you are seeing here, this is the way the foam is looking in the ultrasound, is looking like white, and that will be the representation of the left fallopian tube that you're seeing here on the screen. Okay, so long story short, the SIS, the saline infusion sonogram, is a very important investigation for checking ovaries, for checking uterus, for checking as well fallopian tubes. Also, we doctors, we recommend to do the SIS for patients that they've been pregnant previously and they had a C-section, because in the SIS, in the scan, we also can assess something that is common to a certain degree, that the name is isthmocele, meaning that in the scar tissue of the C-section sometimes could be a collection of liquid, and that liquid could be embryotoxic, so it can affect the implantation of other embryos. That's something that we normally, when we do the ultrasound, we can check somewhere here. Okay, so that will be where normally the scar tissue of the C-sections are, and that's what we normally check. Okay, so yeah, this will be the assessment of the SIS, very important again for checking cavity of the womb, checking polyps fiber, checking ovaries, and checking fallopian tubes. This is very common question, is like, Alex, I understood all what you said. I know about the male, I know about the female, I have done the DNA frag, I have done the female fertility profile. All that is fine. I've been diagnosed with unexplained infertility. What's next? What else? And very common, the question is, Alex, what can I do? What can I do? So, well, it is true that it's important for you to understand that, yeah, I mean, it's very difficult. It's very difficult to improve fertility. However, it's important, of course, to follow the recommendation of your doctors, meaning quitting smoking. Of course, smoking affects a lot quality of the eggs, quality of the sperm, particularly the motility of the sperm. Alcohol and coffee. Alcohol 100% is something that we will recommend to cut off as much as possible, because alcohol, again, affects both, but particularly more on male side, the concentration and the motility. Exercise, yes, please. Exercise is something that we always will advise to do 2 or 3 times a week. It's not like one exercise is better than the other, but we will recommend aerobic exercise like running, like cycling, like swimming. That will be the main recommendation. The stress is there with question mark, because you see, we doctors, we read pretty much every day. We are reading articles and we are reading scientific evidence. And the problem is that so far 2023 is stress as such causing infertility. There is no link. But you see, for me, it's very easy to say that as your doctor. But the thing is, like, and we're going to see that in this presentation as well, all treatments, and even if you are not doing treatment, but you are trying at home to get pregnant, there is a financial cost, physical cost, psychological cost, and emotional cost. So the psychological cost as well does matter. So essentially, stress as such causing infertility is not proven, but definitely all what you can do to feel better absolutely will help. And the weight, yes, weight is very important, because sometimes we are finding that patients are getting, for instance, miscarriages, and everything seems to be fine in terms of sperm quality, egg quality, and all that. But the only problem being the weight, okay? And weight, it's, yeah, it could be not like a cause of infertility, but definitely will be a factor that is going to give more probabilities of having a miscarriage or biochemical pregnancy, particularly for patients where the BMI, it is above 30, okay? Ideally, if possible, and I know that this is very easy to say, but very difficult to do, to have the BMI, the body mass index, under 25, okay? If you don't know how to calculate the body mass index, you can go to Google, just BMI calculator, and you're going to see how the weight and the height are considered to calculate this index. Long story short, yeah, weight does matter. Again, BMI above 30, more probabilities of having miscarriages. Okay, treatments. Yeah, so thankfully in Sims, we can offer you pretty much all the treatments that are available, not only in Europe, but pretty much across all the world. So essentially, what you are seeing there is the list of the treatments that we can offer to you. So OI stands for ovulation induction, TSI will be time sexual intercourse, then we have IUI, intrauterine insemination, IVF, in vitro fertilization, ICSI, intracytoplasmatic sperm injection, PGTA, pre-implantation genetic testing for aneuploidy, and then we have social egg freezing, also known as egg freezing, donor egg, donor sperm, and shared motherhood. So this is just to show you that we have low complexity treatments, we have high complexity treatments, and pretty much we can adjust the treatments to your needs, okay? So essentially you can get all the range of treatment with us. Again, if there's particular questions regarding treatments, absolutely you can drop those on the Q&A and I'm going to answer those at the end. So the TSI is one of the initial treatments that we can offer for patients when we are seeing that that time, the time for trying to conceive, I mean, trying for a baby is not higher than 2 years. Okay, when it's more than 2 years trying for a baby and nothing is happening, probably won't be the first option that we are going to recommend for you. We recommend TSI when we have evidence of the following: that the eggs are fine, that the sperm are fine as well, that the fallopian tubes are okay, and for patients that they are being diagnosed with unexplained infertility, or for patients that we know that the only problem is the ovulation, like for instance PCOS, this potentially could be a good option. The downside, I mean, is not very invasive treatment, because the way the TSI works is like, with the menstrual period, female partner, of course, is going to take some tablets, or it could be injections as well, 5 to 10 days. Then they will go to the clinic. They will go to do an assessment scan. We're going to check the uterus, the ovaries. We're going to check the follicle. And when the follicle is ready, we trigger the ovulation. And then we are just telling the couple, go back home, have fun, have a good wine, and please have sex, okay? Because sometimes it's like, Alex, I did all what you told me to do. I had fun and everything. And it's like, did you have sex? No. Oh, okay. So that is not going to work, of course. So it's, yeah, I mean, it's quite obvious, but essentially what I'm trying to mention here is that with this treatment, the good part is that it's not invasive. It's not as invasive as other treatment. That's what I'm trying to say. It's about taking few days medication. But the downside of the treatment is that the success rate, it will never be as high as an IUI or an IVF cycle, okay? Because essentially what we are doing in this treatment is doing the follicular tracking, triggering the ovulation, and then telling you when to have sex, okay? For some couples could be up to 17% chances of success. From this, we need to take like 7 to 10% chances of having a miscarriage. So the overall, most of the times, it won't be higher than 10% chances achieving a live birth rate, baby with you. IUI, well, the intrauterine insemination, in a way, it's similar. In a way, it's similar to the TSI. So essentially, in this treatment, what we do with the menstrual period, we give to female partner gonadotropins. That will be injections on the belly. That's normally for 5 to 10 days again. And then after those 10 days, we are bringing the patient in, we do a transvaginal scan, we check again the uterus, we check again the ovaries, follicle, and when the follicle is ready, we trigger the ovulation. But in this treatment, it is different. We are not telling the couple, go back home, have fun, and have sex, but what we are doing is we bring both partners in, and then we are requesting male partner to produce a sperm sample, and then we spin the sample of the sperm, we select the best swimmers, and then transvaginally we put them inside into the womb. Because of the fact that we are giving medication for the follicular development, because we are triggering the ovulation, because we are selecting the sperm and placing the sperm at the right time in the right spot, because we're doing the 4 of this, success rate will be up to 20-25% chances of having the beta HCG, the pregnancy test, positive. Okay, but again, we always need to consider as well the probabilities of having a biochemical pregnancy or miscarriage, and therefore the overall, it won't be higher than 16 to 18, and in very, very good scenarios could be up to 23%, as you can see there on the screen. Okay, so that's another option. And then we have the IVF. So the IVF cycle, so essentially the IVF cycle has 5 stages. So that will be the preparation, the ovarian stimulation, the egg collection, the embryo transfer, and the pregnancy test. We're going to see all those in a minute. But essentially, this will be recommended, for instance, when we know that the egg supply, it is low, and we need to maximize chances. And in order to maximize those chances, will be to try to give medication to produce more follicles, more eggs, and therefore more chances of getting an embryo that potentially can give us the baby. So that will be the one of the reasons. Other reason will be low sperm concentration. So the other techniques, the TSI or the IUI, which are considered low complexity techniques, they will not work if the sperm concentration it is low, for instance. So we need to go with an IVF ICSI fertilization, for instance. Okay. So the process is here, just what I was telling you before. So we do the assessment, of course, we do the initial consultation, return consultation, all the investigation that we just mentioned. And when we know that a couple is going to require IVF, so essentially there's preparation that couple needs to do. On both sides, we will recommend a multivitamin. Also for men, there's some supplements that we will recommend, like for instance, CoQ10. So the CoQ10, it's important. It's important for getting good sperm motility, for instance. And in the other side, on females side, it will be important to get the CoQ10 because, of course, that also can help with the energy of the eggs. Okay, so there's some sort of preparation. So then, with the menstrual period, then it will be like 10 days of stimulation, ovarian stimulation, meaning injections on the belly. Afterwards, it's going to be the trigger shot, then the egg collection, and then, of course, the fertilization, and then the embryo transfer 5 days afterwards. The process altogether is it potentially can take up to 5-6 weeks. And with this treatment, of course, the success rate, the probability of getting pregnant, is given by 4 main factors. Is given by age, both partners, so male and female. It's also given by the sperm concentration. It's also given by the AMH, and it's also given by the number of eggs that we can retrieve on an egg collection. So it's not the same retrieving 5 eggs compared to retrieving 15 eggs. Okay, so those are the 4 factors that you need to consider in order to get an accurate success rate. Okay, and that's the reason why we doctors we have a calculator. So essentially, when we are doing the initial consultation or the return consultation, and we have all the parameters, age, AMH, sperm concentration, so we can tell you what will be the likelihood of getting pregnant with an IVF cycle. Okay, so the other treatment that we also have in SIMS will be genetic testing. Okay, so PGTA means pre-implantation genetic testing for aneuploidy. And this treatment, it is vinculated to an IVF cycle. So essentially what we do in this one, it is an IVF cycle with ICSI, with ICSI fertilization. So we create the embryos. Once we have the embryos, we let them grow up to the blastocyst stage, which is day 5. And then on day 5, we are taking a biopsy of the external part of the embryo that the name is trophectoderm. So we're taking 5 to 8 cells, okay? And once we have the biopsy taken, we get the embryo frozen, and the biopsy is the one that we send to analyze. Our partners that we work with genetics they are based in Czech Republic. So we are sending the samples to Czech Republic. And then after 4 or 5 weeks, we are getting the result back, meaning that we are, after 4 or 5 weeks, in a good position to telling you of the embryos that we have biopsied, the quality of them. But you see, now that I'm talking a little bit about quality, it's important to understand that when we are doing an IVF cycle, and we are telling you, when we doctors, we are telling you, oh, this is a very good quality embryo, please ask the doctor, what do you mean with good quality embryo? Okay, because quality, we always have the external quality and the internal quality. Okay, if PGTA it is not performed, doctors only, we can tell you about the external quality. I mean, I'm saying doctors, but also embryologists. Okay, so the lab team. And the external quality is given by the way the embryo is looking, expansion, number of cells, all this. And we give to the embryos a grading like 4BA, 5BB, okay? There will be more webinars and embryology, they will explain you this, but long story short, for instance, 4AA will be like a top quality blastocyst, very fantastic quality blastocyst. But remember, that's only the way the embryo is looking. When it comes to internal quality, 2023, we can assess only one component of the two main components of the internal quality. So we can check the genetic of the embryo, and that's the reason of this investigation, checking the genetic of the embryo. And I'm talking here about the total number of chromosomes, okay? In order to create a new human being, we have the egg, the sperm. So each, the egg and the sperm, they have 23 chromosomes. So then when they get together, the resulting embryo should have, not always, that's the interesting part, but should have 46 chromosomes. And then of course we have X chromosome that always is going to come from the egg, and X or Y chromosome that is going to come from the sperm. And the sperm is the one that is going to determine the gender of the child. Okay, so we have 46 XX baby girl, 46 XY baby boy. Okay, so that very simple and basic information is just for telling you that that will be the standard normal procedure, then the standard or normal way of embryo being created. But guess what? Sometimes one egg is sharing not 23 but 21 chromosomes, or the sperm is sharing 25 instead of 23. So the resulting embryo can have wrong number of chromosome. And of course, if there's a wrong number of chromosome, the most likely scenario is that that embryo is not going to attach to the lining of the womb. So then will be an implantation failure. Or if the embryo is capable to attach, that the embryo is not going to progress. And that will be a biochemical pregnancy or miscarriage, okay? This PGTA is the investigation for decrease as much as possible miscarriage or biochemical pregnancy, okay? It is important to highlight that it's not going to increase the success rate, but it's going to decrease the miscarriage rate. In a very simple way of explaining this would be if we have two embryos, okay? So one is genetically tested and the other one is not genetically tested, and both they have the same morphological external quality, both of them, they have 50% chances of giving you the pregnancy test positive. And then you're going to ask me, well, Alex, why would I do the PGTA if they both have the same success rate? Because that's not the end of the story. The beta HCG, the pregnancy test, is not the end. So they both are going to give you the same pregnancy rate in terms of pregnancy test positive, but then the one that is not genetically tested, so the one that is not genetically tested can have up to 15, 20, 25% chances of miscarriage, where the other one only 3 to 5%. So long story short, one embryo can give you 45, 47% chances live birth rate, having the baby with you, whereas the other embryo that is not genetically tested, something in between 25 to 35. So the PGTA overall can give you up to 17% more chances of getting pregnant, if you want to see it that way. If that wasn't very clear, there is no problem. You can drop a question and I'm happy to explain the concept again, but that is the PGTA. And then the other part of the quality, the internal quality that we cannot check, it is the energy. Because very common question is, Alex, I have checked pretty much everything. I did a biopsy for checking for bacteria in the womb. Everything is perfect. And I transfer an euploid embryo. That's the name of the embryo when we know that the chromosomes are fine. And I didn't get pregnant. So then what else? So the thing is, like, even with a genetically tested embryo that we know that everything is healthy and is euploid, there's still an element that we cannot check, and that's the energy of the embryo. And that's the most common reason of having a failed treatment after transferring a euploid embryo. Okay, other options, for instance, if we have tried several times, or we know that the egg supply, that the AMH is very low, and we cannot overcome with banking embryos or doing several treatments of IVF, there's definitely the option of doing egg donation. In SIMS, we do have two programs. They are active at the moment, and we are adding other programs as well. So, but essentially, when it comes to egg donation, we have the program M, which is with Manchester, the program P, which is with Portugal, and yeah, they've been working very well for us. It's fantastic clinics that we are linking in with them, and they're very good. So essentially, the way it works, it's we do the initial consultation, and when we know that a couple is suitable for doing egg donation, we get the sperm sample frozen here, just to give you, of course, the overview. So we get the sperm sample frozen here. We are sending that sample to Portugal, to Manchester. Then in those cities, they are recruiting the donor. The donor is doing a completely full IVF cycle. So then we're getting the embryos. And once we're getting the embryos, we get them embryos frozen on day 5 blastocyst. Then they are coming here to Ireland, and then we do the transfer. That's, of course, the general review. There's more steps in between, but for you to have an idea. We also can offer double donation with we work as a satellite from a clinic that the name is Next Fertility in Valencia. So essentially, with that option, we can help you with the investigations, we can help you with the scans, we can help you with the semen assessment, DNA fragmentation, but at some point, that particular couple that is doing double donation will need to travel abroad to Spain for receiving the embryo, because as you probably know, in Ireland, it will be very difficult to get double donation. And you see, in Ireland, we cannot do anonymous donation. So that is the reason why for receiving the embryo, couples will need to travel abroad, and that's with Next Fertility. Social egg freezing or egg freezing, it will be more intended the treatment for single ladies, younger ladies, that they are looking to kind of having like an insurance policy. It's not a perfect treatment, but essentially what we are trying to do, there's no other option yet, and what we are trying to do is to get eggs frozen. And what we know with this is, of course, that the more eggs we can get frozen, the better the probability in the future to get pregnant with these eggs frozen. Is not perfect, the treatment, because sometimes we are getting X amount, but not all of them are suitable to being frozen. Sometimes the eggs, if they are not good quality, they do not yield good quality blastocysts. Therefore, the probability of getting pregnant not always is great, but it's pretty much what we have. And the recommendation for everybody that is interested in doing social egg freezing, the sooner you come to us, and the sooner you get the treatment plan in place and doing the treatment, the better. Absolutely, definitely. Better prognosis, 30 to 34, 35 years old, 35 to 40, that will be like average prognosis. And then above 40 years old, potentially is not that we will not do it if that's what something that you are interested in doing, but above 40 years old, yeah, so the likelihood of having good result is not great. So I have to be honest. So the ideal scenario will be 30 to 34, 34 to 38, 39 still is good, but above 40, it's something that potentially we will not recommend directly. Yeah, for same-sex couples, we have, of course, intrauterine insemination with donor sperm. We have the IVF option with donor sperm and shared motherhood. And regarding shared motherhood, what we mean here is that if we have a female couple, one partner could be the genetic mother, whereas the other partner will be the birth mother. Okay, so this is essentially something that in other clinics and in other countries, it is known as reciprocal IVF. And it's a very fantastic and lovely treatment to do. Yeah, so this is an option. It's something that we have the license for doing. There's other countries and other clinics that they don't provide this option for patients, but we are very lucky to have this with us. And yeah, so the success rate is always going to be calculated with the partner that is providing the egg, with the partner that is the genetic mother. That will be the way that we will use. If you have the doubt about what will be the success rate, if we're talking about two female, is going to be always given by the partner that is providing the egg. And yeah, for patients, that's single ladies that they want to do this in solo. So essentially, we have same treatments: IUI, donor sperm, and IVF with donor sperm. When it comes to donor sperm, we work with Cryos. Cryos is one of the biggest sperm banks in all Europe. They are based in Denmark. And of course, we have one or two nurses that they are linking in with directly with Cryos, and they are very good, and they're the ones that are coordinated all the cycles that when we need donor sperm. And yeah, and it's working very, very well as well. Okay, and then last but not least, and that's something that I just mentioned before, is about this. So when it comes to doing treatments, IVF or IUI, whatever the treatment is, we need to be conscious about this: the financial cost, the physical cost, the emotional cost, and the psychological cost. And what I'm meaning with this is because sometimes we are very, very focusing on the financial cost, but essentially it's also equally important the emotional cost. And I can tell you, after 14 years of doing this job as fertility consultant, that many of my patients, I'm seeing that the reason why they quit is the emotional cost. For that reason, getting there, achieving the pregnancy, the sooner we can do that, the sooner we doctors can provide that, of course, the better, because the time to pregnancy, it's very important for patients, and it's very important to kind of maximize the probabilities of getting pregnant as well. So I think that's this is the last slide, if I'm not wrong. I'm sorry that I'm being very boring today, but yes, essentially this slide is just for you to know that we know how hard it is. We know that it's tough, the journey, but the patients that they are resilient, that they are flexible, and they are determined, most of the times they succeed. So thank you for your attention today. And again, if there's any questions, I will be very happy to answer them all.
Thanks so much, Dr. Alex. Yeah, there's a few questions that popped in. Obviously, we have only a few minutes left, but we will try and answer as many as we can. But you can send in any further questions. I'll just put it into the chat here, and communications@sims.ie. Some questions that came in were a little bit more specific to that person's situation, so we wouldn't be able to go into it today, but it's no problem. We can get one of the team to give you a call or an email or anything like that next week if there's something that you really want. There's a burning question there and you want, and we've no problem kind of having a chat with you offline on that. So one person there, they were just looking at, they want to freeze their eggs, and they had done an AMH test, which was quite low for them. Is there any tips to improve their AMH or their egg quality?
Yeah, thank you for the question. Well, the first thing that I would recommend is to repeat the AMH. Okay, if we only have one kind of reading, one blood test, and it was the AMH and it was low, definitely I would advise to repeat that one. Sometimes I know that the variation can be not very, very high, but still it's important to have another one to compare with. That's number one. When it comes to improving AMH, it's very, very little that we can do now. Still, 2023, there's no too much supplements that we will advise for kind of increasing the AMH, because pretty much nobody has shown and proven that one particular supplement can be good. The recommendation will be to go with us or to another doctor or clinic and get the treatment done, meaning that, well, the AMH low is not a deal breaker, okay? So essentially it means that potentially, instead of doing only one round and getting 15 eggs, that potentially we will need to do 2 or 3 rounds, okay? But still, it's something doable, okay? So it's not like, oh, the AMH is low, there's no point. No, it's like, the AMH is low, okay, we know that. So then we tailor the treatment and we tailor the strategy to maximize the number of eggs that we can get.
Perfect, thank you. So this one's more of a coffee related question. So what is a good recommended daily safe amount? Is coffee or caffeine in general we should stay away from? Is black tea okay?
Yeah, so in that regards, what we would recommend is coffee with caffeine. Yeah, and I also love coffee, but I'm sorry, it's only 3 cups a week, okay, that we would recommend, okay? It's not like, oh, if you're drinking 4 coffee with caffeine, you're like, oh my God, I'm harming my eggs or my sperm. But when it comes to trying to conceive, that will be the standard recommendation. That will be our recommendation. Of course, decaf coffee you can drink as many as you want. Okay, black tea is fine. There shouldn't be any problems. And what was the other part of the question, Aoife?
Yeah, no, they just said is their recommended daily safe amount of coffee to have per day.
Yeah, up to three cups per week.
Okay, perfect. Yeah, so there's a few here around. There was a question there around PGTA and kind of the success rates around that. And yeah, we do PGTA testing, but I suppose, and what are the chances of a pregnancy in child? I suppose, can we talk?
Yeah.
Is there kind of, yeah, sorry, I'll let you
Yeah,
answer.
just going back to the PGTA. So PGTA, remember, the strategy of the PGTA not necessarily is for increasing the success rate. It's for decreasing the biochemical pregnancy and the miscarriage. Okay, that is the reason why the technique not necessarily is for everybody. Okay, for instance, for younger couples or female under 35 years old, not always is recommended to do this investigation or this process of biopsying the embryos. Having said this, PGTA, the way it works is once we have the genetic information and we know that the embryo that we're going to transfer, it is euploid, meaning that the chromosomes are correct. Most of the times, regardless if this is coming from a 42 years old female or 35 years old female, the success rate, if the embryo is good quality and the outside good, the grading 4AA, whatever, and the internal quality, the genetic is good, the success rate, it will be anything in between 47 to 50 baby at home. Okay.
Perfect, thank you. And then there's just a question around the supplements recommended for good sperm quality.
Yeah, so the main one will be a multivitamin. I mean, there's no one particular brand that I will recommend. You can just go over the counter and get a multivitamin. Pretty much all of them, they're going to have what you need: vitamin D, vitamin B, vitamin C, selenium, zinc. That's one part. And the other one will be CoQ10, coenzyme Q10. There's other supplements, of course, and there's one that are very expensive, other ones that are not as expensive. But the thing here important is that a multivitamin is what we know that can help with the DNA fragmentation, and the CoQ10 with the motility of this. But other than that, it's not also too much that we can do if we're taking more supplements. Those are the recommendations: multivitamin and CoQ10.
Yeah, perfect. And then there's someone asking there about the average cost of treatments. And what I can do is, it depends what treatment you're looking, because they can all vary in cost. You're going from TSI up to PGTA testing, egg donation, they all vary in cost. So what I can do is I'll send an email over the weekend, kind of just summarizing. Obviously, you can avail of the half price consult, like I mentioned. There is a link to the new patient form in the chat there, and I will kind of send it on the price list as well. You can peruse it. And if you have any questions, like I said, just reach out to us. We'd be happy to kind of give you guys a call next week and kind of go through any queries you may have if they weren't answered here tonight. There's a few more that have come through here, but I'm conscious that it's 3 minutes past 7 on a Friday evening, so I'm sure everyone wants to get back to their evening. So yeah, like I said, I will send an email tomorrow morning, and yeah, you just reach back out to us, and we'll set up a call for any further queries. And thank you so much for coming out this evening. I hope you learned loads. I know I certainly do. I always learn loads from these webinars. Thank you so much, Dr. Alex, as well. It's really, really informative, and I hope everyone has a lovely evening. And yeah, like I said, I'll be in touch over the weekend. Okay.
Thank you, Aoife. Thank you, everybody. So I'm sorry, it was my fault, Aoife, today. It wasn't like the 45 minutes that I initially said, but I hope that you have found this webinar interesting, that you have found this informative, and thank you so much for having me.
Perfect. Thank you. Thanks, everyone. Bye.